Welcome back to another explainer. Look, we all know primary teeth are temporary, but structurally, they're pulling way more weight than most people give them credit for. Think of a primary tooth as a critical biological guide path, literally nature's blueprint for the permanent teeth waiting in the wings. As the old clinical adage goes, the absolute best space maintainer in the dental arch is just a healthy primary tooth. But what actually happens when that natural blueprint gets lost way too early? Let's get right into it.
Today, we're mapping out our clinical journey through 5 key areas. We'll hit the tooth loss domino effect, enter the space maintainer, the clinician's toolkit, mastering the distal shoe, and finally, the clinical decision matrix.
Starting right off with Section 1, the tooth loss domino effect. We need to look at the pathology here to set the stakes for why clinical intervention is just so absolutely critical.
So what exactly happens when a primary tooth leaves the party too early? Whether it's from rampant decay, trauma, or deep nerve pathology, it doesn't just leave a harmless little gap. Premature loss is honestly a biological ticking time bomb. It instantly disrupts the physiological equilibrium of the developing occlusion. Without that tooth holding its ground, the surrounding architecture starts to shift immediately.
This sets off a really rapid domino effect. Driven by normal biting forces and the contraction of gum fibers, that permanent first molar has a massive tendency to drift forward or mesially. Meanwhile, your anterior teeth might start tipping backwards or distally, and the opposing tooth, without an antagonist to chew against, it can actually over-erupt, totally wrecking your vertical space. The endgame here is a severe loss of arch length, crowding, and sometimes even the impaction of the permanent successor. And here's the absolute crucial clinical pearl you need to remember. This space closure happens most aggressively within just the first 6 months following extraction. Time is definitely not on our side.
Moving on to Section 2, enter the space maintainer. To put the brakes on this aggressive domino effect, we need to bridge the gap between preventive and interceptive orthodontics with a very specialized tool. Let's ground ourselves in a bit of academic authority with this classic definition from McDonald and Avery. They define the space maintainer as a dental appliance that maintains the space left by a prematurely lost primary tooth or a group of teeth, preventing the adjacent teeth from drifting into the edentulous area until the permanent successor erupts. Basically, it's the hero of arch preservation. It's an active placeholder, holding the line for the permanent dentition.
Now, check out this number, 3.4 millimeters. This exact measurement represents the total mandibular leeway space, sometimes called the leeway space of Nance. You know how the combined width of the primary molars and canines is actually larger than the permanent premolars and canines that will eventually replace them? Well, in the lower arch, that gives us about 1.7 millimeters of extra room per side, which totals 3.4 millimeters. Think of it like a natural physiological savings account of space. By properly using appliances, we can preserve this exact amount of space to relieve future anterior crowding. It's practically free real estate if we manage it right.
Which brings us to Section 3, the clinician's toolkit. Now that we've laid out the stakes, let's open up the toolkit and explore the appliance arsenal we have at our disposal.
Your very first major clinical decision is choosing between a fixed and removable appliance, and this is really all about balancing patient variables. A fixed appliance is cemented in place. It's incredibly reliable because, let's face it, you don't have to worry about a highly distractible 5-year-old remembering to wear it. But they are much harder to clean and definitely carry a risk of decay if the patient's hygiene is terrible. On the flip side, a removable appliance, like a modified partial denture, is super easy to clean, plus it can restore aesthetics and masticatory function. But it requires incredibly high patient cooperation. We've all seen them get lost, broken, or just permanently abandoned in a retainer case.
If you do go the fixed route, your choice relies entirely on the arch geography. Dealing with unilateral loss on just one side? The band and loop is going to be your absolute clinical workhorse. If the abutment tooth happens to be heavily decayed, you'll probably want to upgrade to a crown and loop. Now, if you're looking at bilateral loss, you've got to cross the arch. Up in the maxilla, you'd use a Nance palatal arch or a transpalatal arch to prevent forward migration. Down to the mandible, the lower lingual holding arch is your standard go-to. But a quick reminder, you generally want to wait until the permanent lower incisors have fully erupted to place that one. Otherwise, the wire might physically block their natural eruption pathway, and we definitely don't want that.
Let's look at the practical step-by-step workflow for fabrication and cementation in the clinic. Following these clinical steps to a T ensures a passive, totally accurate fit. You start by placing orthodontic separators 3 to 5 days prior to make some room.
Then you try on and snugly adapt your stainless steel band, take an alginate impression with that band securely in place, and ship it off to the lab where they'll bend and solder a 0.036-inch wire. But step 5 is where the real magic happens. We cement these primarily with glass ionomer cement, or GIC. Why? Because GIC gives us chemical adhesion and, crucially, a continuous release of fluoride. It literally acts as a shield, protecting that abutment tooth from demineralization right underneath the band.
All right, section 4, mastering the distal shoe. We need to focus deeply on this highly unique subgingival appliance because it is a massive favorite on board exams.
You see, most space maintainers guide teeth that are already physically in the mouth. The distal shoe is a totally different beast. It features a surgical intraalveolar extension, literally a metal blade that goes subgingival, straight down into the alveolar bone. So why do we use it? Well, this subgingival guide rail is strictly indicated for one very, very specific scenario: the premature loss of the primary second molar before the permanent first molar has even erupted. Because that permanent molar uses the distal root of the primary second molar to guide its eruption path, losing it means the permanent molar is just going to drift blindly forward while still stuck inside the bone. The distal shoe acts as a substitute, an artificial guiding wall for it to follow.
But, and this is a huge but, because this intraalveolar blade creates a persistent, open epithelial breach right into the gum tissues, you have to be incredibly vigilant. You must absolutely avoid using the distal shoe in immunocompromised children or those with cardiac defects, due to the severe risk of heart infections like subacute bacterial endocarditis. It's also completely contraindicated for kids with bleeding disorders, insufficient bone coverage, or just historically poor patient compliance. It's a prime example of why treating the whole patient and not just looking at the tooth is absolutely paramount.
And that brings us to section 5, the clinical decision matrix. Let's take all this academic theory and tie it right into actionable, real-world treatment planning.
Think of this as your ultimate cheat sheet for clinical practice. It brilliantly summarizes your treatment choices based on specific patient variables. Mandibular primary second molar lost before the permanent molar erupts? Boom, distal shoe. A simple unilateral loss of a maxillary primary first molar? Band and loop all the way. What if a child loses multiple front teeth to early childhood caries and you've got speech or aesthetic concerns? A removable partial denture is a really fantastic functional choice there. And for bilateral loss of those lower primary second molars, you're going to turn to the lower lingual arch. It really is just about perfectly matching the biological reality with the right mechanical solution.
Honestly, sometimes the absolute smartest clinical decision you can make is knowing when to just hold back. You don't actually always have to intervene. If the permanent successor is clinically visible, you definitely don't need an appliance. Or, more scientifically, if you take a radiograph and see that 1/2 to 2/3 of the successor's root has already formed, that tooth is actively pushing its way through the bone and will erupt very soon. Plus, we generally skip maintainers for lost primary incisors simply because space rarely closes in the anterior region